maybe this is a great topic for thinking about, how do we talked a little bit earlier when we're thinking about timing, and you just mentioned, like how long should people be remaining on the IO TKI regimens? Most people, I think, remain on TKI. That's how the trials were done. How do you all manage patients who are getting maintenance PD-1? Do you continue forever as the trial did, or do you all stop at 2 years? Or
Yeah, certainly my practice has changed over the last 5 years. Basically, initially when all the CheckMate 214 data came out, we were continuing the PD-1 inhibitor nivolumab for as long as patient is tolerating and the tumor is responding based on the clinical trial data. But now as we get more experience and we get more comfortable with this agent, especially with David data from the treatment-free survival, which seemed encouraging. So we feel much more comfortable now holding treatment, especially I sometimes actually do not even continue up till 2 years if I achieve a deep response or whether deep partial PR or complete response on 2 subsequent scans. I'm encouraged on a case-by-case scenario, and after careful conversation with the patient, I'm encouraged to give them a break. And I have done this strategy repeatedly. I do not recall regretting doing it. And in the few patients that come to my mind where their disease progressed later on, when I re-challenged with immunotherapy, with nivolumab, basically they did benefit from this again. So that approach has not yet, what's the word I'm looking at? I did not follow this approach in the IO TKI yet. I feel a little bit more nervous on holding the TKI part of it. Certainly, I'm comfortable holding the immunotherapy. A lot of times, based on the clinical trials, the clear or the keynote, we are stopping pembrolizumab at 2 years, basically. But even sooner than that, I'm still hesitant to hold the TKI early on, especially if they had, high bulk of disease to start with.
Yeah, that sort of raises a question in my mind. I don't know how the rest of you do this. Do you, in terms of treatment holds, do you approach this differently, whether you're treating the patient with ipi-nivo, like pure immune therapy, versus the TKI IO therapy? In my practice, I typically will seek to have a treatment holiday if they're on ipi-nivo, and typically I do that at 2 years. But when they're on a TKI IO therapy, because I'm not seeing this immunological synergy, I feel sort of compelled to continue both treatments as long as they're working. And if I stop anything, it will periodically be the TKI therapy because,
Yeah, certainly we do this hold on the TKI if they're having side effects, or even hold and decrease the dose. And I think we have enough real world data now about the necessity to hold and the TKI and reducing the dose without necessarily impacting the efficacy. But I would be still hesitant to completely stop the TKI part, although I would feel much more comfortable with holding for a prolonged period of time the IO part.
David, Pavlos, Katy, do any of you do it differently?
So no, I completely agree with all the points stated thus far. One thing is, for example, as mentioned with the CLEAR trial, pembro and lenvatinib, even if we wanted to, because the trial was designed to hold the pembro after 2 years, insurances will not typically, let you continue this. That 2-year cutoff is arbitrary. It's not like it came from the mountain, as a law that, we have to follow. But it's a nice landmark, regardless, to discuss. So, the cleanest way to think about it is, with nivo maintenance after, nivo-ipi in a patient that's responding. I completely agree with the idea that it's patient dependent. You have to discuss this with patients. It's something we say all the time because it's real. The patient values are important, but also there are some clinical factors. For example, if you have somebody, let's say, around the 2-year mark on nivolumab maintenance, and now you may be seeing something stirring in their disease, do you really want to stop now the therapy, you're not going to know whether things are moving because you stopped or not. So there are some considerations that can play a role as well.
And David, do you think stopping the Pembro or the Nivo and Cabo-Nivo at 2 years, do you think that is contributing at all to the decrease in the tail of the curve there?
I could be, no question about it. But essentially we need to study it. We've sort of avoided that question in a prospective way. I mean, because if you look at the early days of PD-1, just in melanoma, for example, you stop at 2 years, people on drug, 90% of them stay in response. In kidney cancer, that number is almost certainly smaller, but we don't know how small. If you just look at the data from 214, the number of responders that stay responders over time is 50% or north of 50%, but it's not 90%. So getting real data, and which we wouldn't necessarily need to be a prospective industry-sponsored trial, be something we could potentially collect out there, would help inform practice, because as Pavlos was saying, we're certainly over-treating some patients. The 2-year mark is totally made up out of nowhere. But there's some patients who probably have PD-1 deficiency. So if you stop the drug, their cancer will grow. And it becomes a very difficult issue with insurance restarting in that situation, because more and more I'm noticing insurance saying no to re-challenging, and that's why we need prospective data, because it really impacts treatment when we don't have it.
Yeah. I've liked seeing the data that each of the frontline trials have done, where they've looked at tumor shrinkage and us recognizing that if somebody meets some threshold, again, an arbitrary 60, 70, 80%, that those are the patients who tend to do almost quite as well as the CR patients. And so I think for me, even in my IO TKI patients, if we get that kind of a deep response, I feel a little bit more confident. And it is always certainly a discussion of what's the patient's fear and concerns, and what risks and what are the current side effects. But I try to do or consider doing a break for either of the regimens. So.
Yeah, I will say to your point, I think it's always an interesting parallel when we think about, treating melanoma with immune therapy versus kidney cancer. Oftentimes they're kind of lumped together as these twins, but actually the responses can be quite a bit different.
Yeah.
So if you look at, I readily agree, we definitely need more data to answer some of these questions. But in my opinion, we do have some sort of teasing or hint of the data if you go back and look at the Checkmate 025 study, which was single agent nivolumab versus everolimus, as you remember. And I can't remember exactly what year, but a couple of years ago, Bernard Escudier presented some really long-term follow-up of that data at ESMO. I'm going to say it was 3 years ago. And the proportion of patients that still were maintaining a progression-free survival was pretty low, with their median follow-up of 7 years. So, which is much different than, has been reported with melanoma.
Right. The diseases are certainly different. We could use more data. We could use more conclusive proof that CTLA-4 is adding something. 8x8 will inform that information, and we'll see. But we need to keep pushing for more information for our patients.